This is Dr. Caroline Watson with Dr. Rob Weinstock. This is our bimanual cataract surgery instrumentation video series sponsored by MST Instrumentation. This is episode 8 of our series, and today we are showcasing a 4-point scleral fixated secondary IOL in a Marfans subluxated lens complex. We are using some of the same instruments that we use on a regular basis, just going through these main instruments just to give you guys another quick view of these bimanual instruments that we use every day. Each one of these is made by MST. Some of them are a customized type of instrument, especially made for our practice. And we really appreciate MST and the quality of their products. We use bimanual phacoemulsification as well as bimanual IA in these videos and in our regular everyday cataract surgeries.
So starting the case here, we see an obvious superior dislocation of the entire lens and capsular complex secondary to the Marfans. We start by using a cystotome to initiate a hole in the capsule, but then switching quickly to a MST microcapsulorhexis forceps, trying to center the capsulorhexis as best we can, even though it's limited view. But you can still see it's possible, even though the lens is dislocated, to make a complete capsulorhexis. Then we use MST capsule retractors to try to capture the actual edge of the capsule between the cortex and the capsule and try to pull the whole lens complex back into a more neutral position centrally in the eye where anatomically we want it to be. And you can see once it's centered how well centered the capsulorhexis is made based on the earlier visualization. Now once the capsule is secure with either 3 or 4 hooks, we do a bimanual INA. Remember, this is a Marfans case, a very soft lens. So we don't need phaco. The INA is a much more controlled procedure. So with the irrigating chopper on the left side and the aspiration bimanual handpiece by MST on the right side, we're able to remove the entire lens and cortex. So now, at this point, we have a very, very unstable capsule. But we've gotten the lens out, and we use the previously placed 25 gauge vitrectomy port to do a posterior vitrectomy and an anterior vitrectomy, because we know we have vitreous up above into the anterior capsule. And we actually remove the whole capsule with the vitrector very easily. So now we have a completely empty eye, with anterior vitreous has been removed, and we take a bent 27 gauge needle, and after we've marked the sclera, we introduce it in the eye and we do a little handshake technique with this suture. And we'll place the suture through the smaller wound, and this is a 6-0 suture we're using, polypropylene suture. And that is the Akreos AO lens that we use for this technique. And after one of the sutures is placed through the eye, we then thread the suture through these 2 holes on either side of the optic. And then we repeat a similar mechanism on the other side, where we introduce the needle transconjunctivally through the sclera, approximately 4 millimeters back, a little handshake technique to pass it out through the sclera. And this is a separate piece of suture from the first piece. We thread that through the optic, and now we have the entire optic outside the eye, but we have 2 of the sutures placed through the sclera. Now, with keeping the optic outside the eye, we'll grab the free end of the suture that we haven't worked with yet, and we'll introduce it in the eye, take the 27 gauge needle, and we're using a micro forceps threaded up into the needle and outside the eye. And once we do that on all 4 points, now we can introduce the lens into the eye through the wound. Now we've already started to create some flanges on the hinges. Once the lens is inside the eye, we want to seal this eye up. So we're going to put a suture in to secure the wound. Once that is in place and the eye is well sealed and watertight, now we can begin to pull these suture ends to center the lens visually into the pupillary axis. And little by little, once the lens is centered, we can singe these little flanges down, little by little, one at a time. And we put myocol in to bring the pupil down. That helps center the lens as well. And once we've singed it down and it's well centered, then we can tuck them under the conjunctiva.